Hello, my name is Mishek Ruwende. I am a medical student, and with me here is my poster about the world healthiest diet, the Mediterranean diet. A diet which is traditionally found in the countries which borders the Mediterranean Sea. The countries like Greece, Italy, and all the other areas of southern part of Europe. A diet which is now being adopted the world over. We know that non-communicable diseases are on a sharp rise. We know that they are causing 70% of the burden of deaths worldwide. We also know that 60% of deaths in the developing world are being caused by the non-communicable diseases. Non-communicable diseases like cancers, hypertension, diabetes mellitus, and other heart-related conditions, as well as strokes. And for that reason, we see that since 60% is being found in the developing countries, we see that it's now high time we focus on preventing these diseases in developing countries. It may not be because the incidences are high in the developing countries, but because of our poor health system and our poor medical infrastructure. And for that reason, as the developing world, we should focus more on prevention than treatment. They say prevention is better than cure. But unfortunately, for most non-communicable diseases, they are not curable, but you can treat them. And therefore, we say prevention is better than treatment. And therefore, the Mediterranean diet is the optimal diet for prevention of these diseases. A diet in which some they call a lifestyle which includes exercising every day. Remember, in these areas, especially around the 1940s and 1950s, these were mountainous areas, and these people would exercise every day. And therefore, we are saying, according to this lifestyle or this diet, exercising is every day, at least 30 minutes per day. This is a plant-based diet, a diet we are talking of taking vegetables and fruits every day. We should also replace the fat, the saturated fat, with the olive oil. We know we like sprays, we like margarine and etc. But why not replace it with avocado? It is one of the most nutritious fruit, but we can also use it as a spread for our bread. What type of bread? According to the Mediterranean diet, we are encouraging more of the whole wheat bread, the brown bread. And we should also avoid the processed foods. We can also use spices like garlic, like the mint and the wormwood, even the rosemary. Ladies and gentlemen, comrades and friends, remember, the healthiest non-alcoholic diet is water. So what are the main uses or prevention of the Mediterranean diet? As I have mentioned earlier, type 2 diabetes we have here, prevention of the heart diseases. There was a study in 2011 which shows that serving extra fish per week would reduce the probability of you getting heart disease by 50%. It also increases the life expectancy by around 20%. It reduces the probability of you getting diseases earlier, like the Alzheimer's and the dementia. It can also help in preventing the colon cancer. In summary, ladies and gentlemen, I am saying, let us all adopt the Mediterranean diet, especially the developing world, as a way of curbing and preventing the mortality and morbidity caused by the non-communicable diseases, and as a way of developing our world. Thank you.
My name is Privilege Ujoma from the University of Zimbabwe. Today I will be talking to you about prevention of mother-to-child transmission of the HIV virus, with more emphasis on policies that are being implemented in Zimbabwe. Robustly saying, most of the units in the Ministry of Health have been implementing PMTCT in an effort to reduce the prevention of mother-to-child transmission of the HIV virus. But from 2016, PMTC rate was sitting at around 30%, and due to the robust implementation of these policies, we have greatly managed to reduce transmission of the HIV virus to about 5% to 7% by 2016, which was a very tremendous and broad move by the Ministry of Health in Zimbabwe. But realistically speaking, based on research that has been carried out, that is still being carried out at the university at the moment, we have noticed that regardless of robust implementation and successfulness of the PMTCT programs, there are still some of the infants that are seroconverting. We are all aware of the fact that the Ministry of Health is putting emphasis in exclusive breastfeeding of infants up to 6 months. And regardless of that, we still get some of the infants seroconverting. And our question as scientists is, why is that happening? So to answer some of those questions that are constantly coming up, I have personally went on to try and see where there is a gap, where and why are we getting some of these infants seroconverting. As much as a noble thought could be, it's really expected that a program cannot be implemented 100%, but I'm saying, where are the loopholes? Where can we bridge to actually get to a point where we say each and every child that is born is kept negative, regardless of the fact that they are born from an HIV positive mother. So the policies that the ministry has put in place, I've realized that not all of them are being adhered to in terms of some of the healthcare facilities that are there to implement these, but then some of the time the information is not being channeled through the right channels to the mothers. And the other thing is, are they also cost effective? In our setting, we are saying we are in a developing country, and all of us are quite aware of the current economic situation. Are all the mothers out there capable of adhering to the policies that are in place? Because some of these would require traveling to health facilities, and some of these facilities are probably a long distance away from the residences of these mothers. So the vertical transmission, as shocking as it could be, the Ministry of Health has gone on to put health centers across the country to try and make sure that each and every woman has access to these facilities. Each and every pregnant woman, so to speak, has access to these facilities. But there is an option of other women who are giving birth at home. They don't even have access to PMTCT services. And still, some of these patients, some of these mothers are HIV positive and are still giving birth without the necessary health care that would prevent the transmission of the virus to the infant. And the other issue, as I addressed before, is accessibility to the healthcare system. We have, like, rural areas, to be specific. Most of these mothers stay in areas in which once they are to deliver, they do not have the capacity or the resources to shuttle them to the health facilities, which are probably kilometers away from where they will probably be staying. Hence, they would opt to give birth at home, or even give birth along the way, giving a risk to the infant who will be born. And there is need now to focus our resources of PMTC programs in resource limited settings in the country, in order to make sure that each and every pregnant woman has access to these services. By so doing, we could probably eliminate the transmission of the virus. But there will be a lot of challenges faced by this. To begin with, we would need to do health promotion and educate the nation, educate the people, educate the women. Not only the women, but also the men. Also allowing access of art services to the men, because it's not only the women that are involved in this process. So we include both parties, the females, the pregnant mothers, and the men, and we educate the people on the benefits of PMTCT. Though this has been going on, I think it will be an angle in which we could improve on what we are currently doing right now. And as to access, we need to take access, PMTCT services, to the people, to those who are in the rural areas. We need to make sure that they have access to PMTCT services. And it would take the government or the Ministry of Health in mobilizing the nation and mobilizing resources to channel into PMTCT programs. And as far as early infant diagnosis is also concerned, we have limited facilities around the country. Obviously, I'm talking of down at district levels. Not much is being done in terms of early infant diagnosis. And we need to make sure that AID services are channeled down to the lower levels of health delivery services. Also getting to a point where we could actually have access to viral load determination at those lower levels in order to make sure that we monitor these infants and we monitor these mothers as before they give birth. So we need outreach programs that identify HIV positive pregnant mothers in the communities and then extract them and provide the PMTCT services to them. With that and other things in mind, the 2015 data from the guidelines and the data, that summary that was generated by the Ministry of Health, it shows that 80% of the women who have had access to PMTCT programs, but we still have that percentage that's still not getting access to PMTCT programs. So I think it's an initiative that we all need to take up as scientists and as healthcare providers to be able to get this information to the people so that people understand the benefits of PMTCT and prevention of transmission of the HIV virus to the infants. Thank you.
Hello, my name is Dr. Sekesai Zinyowera. Greetings from the Ministry of Health and Childcare. I'm the National Microbiology Reference Lab Coordinator, and I'm also the Antimicrobial Resistance Coordinator. As you know, that antimicrobial resistance has been declared as a World Health Threat at the 68th World Health Assembly that took place in 2015. Now, antimicrobial resistance is when antibiotics or antivirals or antifungals or antiparasitics that are normally used to treat infections are no longer working. And this can take place as a natural phenomenon, or it can also be caused by our irrational use of these antimicrobials. And after this World Health Assembly, us as a country, we decided that we held a One Health workshop whereby people from the Ministry of Agriculture, people from the Ministry of Environment, from the Ministry of Health, from the universities, and other sectors that are relevant, we actually met and we formed what is known as a core group, which actually is a chairperson, and I was chosen to be the coordinator of this AMR in short. So what we did is that we actually did a situation analysis on antimicrobial resistance. And our findings concerning the situation analysis are that we found out that in humans, the diseases that are actually causing high mortalities acute respiratory infections, meningitis. Whilst in cattle, it can be hot water fever. And the antimicrobials that are mostly being used, especially for humans, are actually ceftriaxone, especially in private and central hospitals, whilst benzyl penicillin is being used maybe in district hospitals or infectious disease hospitals. And we also did a national CAP survey, that's the Knowledge, Attitudes and Practices survey, asking different professionals how they deal with issues of antimicrobial resistance. There is actually irrational use. We know some nurses, they actually give antibiotics when somebody has got flu, even a few doctors, and yet flu is a viral disease. And in our laboratories, there's a shortage of manpower, there's a shortage of reagents and equipment, and also sometimes they can actually be testing antimicrobials that are not even present within the hospital. So even that means it's rendering their results useless. And also in the animal field, you find out that the most used antimicrobial is actually oxytetracycline, which is used both in ruminants and even cattle. And also antimicrobials are also even used in plants, especially fungicides and some bactericides. So even in the feeds of animals, antimicrobials can also be used as growth promoters. But there is also ways that you can actually prevent antimicrobial resistance, that is by practicing good infection prevention control within our hospitals and biosecurity for animals, and also vaccination, but our vaccination rate currently is at 89%. So after having seen the situation on the ground, we now wrote a national action plan concerning how we are going to deal with this issue in Zimbabwe. So this national action plan is an operational plan, an M&E plan, and we have even costed the document. And there are 5 thematic areas that are according to the global action plan. These thematic areas are education and awareness. There's need to educate and make people aware of this scourge. There's also issues of laboratory. There's issues of research and surveillance. And the third issue is infection prevention control and biosecurity. The fourth one is rational use of antimicrobials. And the fifth is innovative research. What other vaccines can we produce? What other antimicrobials can we produce? Or are there even alternatives of antimicrobials? So this is how our national action plan is. But our national action plan is from 2017 to 2022, and we have started implementation of this national action plan. We have started the One Health antimicrobial laboratory surveillance system, whereby we are only initially just looking at Salmonella and E. coli, and specimens are being taken from humans, that's blood, urine, and stool, and for animals, they're taking from poultry samples, including those from cattle, and we are looking for these particular organisms. Even for the environment, the Harare City Water, including the Environmental Management Agency, are also testing water for these particular organisms. And all these isolates, if they are isolated Salmonella or E. coli, they're actually taken to the National Coordinating Center, which is the National Microbiology Reference Laboratory. So we have started something so that we can see the resistant patterns of antimicrobials, because it's only through the lab that you're actually able to see whether an organism is resistant or resistant or susceptible to those antimicrobials. And the other issues that we have started is the education and awareness part, whereby we have done radio shows on ZFM or Radio Zimbabwe in Shona, or we have gone on TV on Good Morning Zimbabwe, or even last year we were on Melting Pot, and we have even done road shows in Epworth, in Mbare, in Kwadza, and in Glenview, and also including some public lectures at our Harare City Library. And also we've even done lectures to other professionals. So this is how we are also now implementing issues concerning antimicrobial resistance. And of course, there is need for more funding and more support and government input, but we are glad that our ministers in both And our permanent secretaries in all ministries of health, of agriculture, and environment, they've all signed this document, and they are all abiding to this particular document. And now that we're in the implementation stage, we're actually implementing together as One Health. Thank you very much.